Hello everyone, thank you all for joining today's session. I am Lakshmi and I am currently working as a clinical pharmacologist. I am also a member of FCPI Oncology Forum. Today I am very excited to start our very first presentation of FCPI Oncology Forum and we are honored to have Dr. Sai Vikas as our speaker. Today's topic of discussion is Introduction to Oncology. Thank you Dr. Vikas for choosing this topic. Short bio about the speaker himself. Dr. Vikas had completed PharmD in Bharati College of Pharmacy, Karnataka, and currently working as an oncology clinical pharmacologist. And he had an experience of 5 years. Dr. Vikas will take over the session further.
Thank you, Dr. Jnanalakshmi, for the introduction. And my name is Sai Vikas, and I do not have any relevant financial relationships with any commercial interest. So, coming to introduction to oncology, oncology is a branch of science which mainly deals with the cancers, and now presently cancer is the most leading cause of death worldwide. So, let's get into the topic. What is oncology? Generally, the word oncology is derived from a Greek word onkos, meaning tumor or volume or mass. So, oncology is the branch of science dealing with the prevention, diagnosis, treatment, and also the study of cancer. So, whereas cancer is a group of diseases where the cells grow and multiply uncontrollably. So generally, a normal cell, like a normal somatic cell, which is non-cancerous and non-stem cells, especially. So normal cells live up to 40 generations and die when they build up excess genetic errors. This is also called as Hayflick limit. So generally, the cancer cells has three stages, which is initiation, promotion, and progression. So in the initiation, uh, so initiation is an irreversible genetic damage which causes the initiation of cancer, and promotion. Here the cells start the clonal expansion, and they start the progression, and the progression means malignant transformation, and which is irreversible, and it also spreads to other parts of the body. So can we go to the next slide? So in oncology, we have different departments like medical oncology, which deals with the use of chemotherapy, immunotherapy, hormonal therapy, and other drugs which are used to treat cancer. And radiation therapy deals with the use of radiation therapy to treat cancer. Radiation therapy is the use of ionizing radiations which cause DNA damage, and the cancer cells are less uh, so uh, the cancer cells are less efficient at repairing the DNA damage. And surgical oncology, this deals with the surgery and other procedures which are used to treat cancer, which may be invasive and non-invasive. And hemato-oncology deals especially with the cancers of the blood, bone marrow, and the lymphatic system. So can we go to the next slide? So coming to the agents which cause the cancer, here we have mainly two categories, which is mutagens and carcinogens. Mutagens are generally the substances which cause alterations in the genetic material, and there are many types. I have just mentioned few types, which is a point mutation and frame shift mutation. And carcinogens, these are the compounds that induce serious mutations to DNA that can lead to cancer. So coming to the epidemiology, here you can see the incidence or prevalence rate of cancer in males and females. Males to the left side and females to the right side. Next slide, please. So in 2020, we had around 13.2 lakhs of cases, and which has increased to 15.7 lakh cases in 2025, which is higher than the inflation rate. And coming to the incidence rate, new cases per year is approximately 1.6 million cases. and incidence of cancer cases which are leading to death per year is approximately 0.9 million cases. India contributes to about approximately 10 to 12% of global cancer burden, and there is a lifetime risk of developing cancer in India, which is approximately 1 in 9 people. So coming to the most common cancers in men, which are lung, oral cavity, esophagus, stomach, colorectal, and prostate cancers. And whereas in women, we have breast, cervical, ovary, gallbladder, and colorectal and lung cancers. So coming to North India, we have head and neck and esophageal and stomach cancers. In South India, we have stomach and liver cancers, and whereas in metro cities like Hyderabad, Delhi, we have breast, prostate, and colorectal and thyroid cancers. Next slide. So coming to the causes, see, there are many causes of cancer which includes physical factors. These ionizing radiation such as the gamma and X-rays and UV rays, and chemical factors. So coming to the chemicals, we have different type of chemicals, and also the tobacco. And biological factors, we have viral oncogenes, proto-oncogenes, and also cellular oncogenes. So coming to the risk factors, so alcohol intake, chronic alcohol intake, smoking, and improper diet or diet timings, and UV exposure, lack of physical activity, obesity, and family history of having cancers, and old age and chronic infections. These are all the risk factors for causing the cancer. So coming to the type of tumors, there are three types, which is benign tumor. Benign tumor, they are generally non-malignant. They do not spread, and they also do not grow once removed by the surgery. And pre-malignant tumor, see, these have the characteristics of a malignant tumor, but they don't have the ability to spread, but have the potential to become cancerous. They have high risk of being cancerous. And malignant tumors, these are generally cancerous and grow rapidly and also spread to the other tissues. So coming to the hallmarks of cancer, uh, so coming to the hallmarks of cancer, we generally had around 6 classical hallmarks, which were first introduced in the 2000, and also we have expanded hallmarks which were introduced in 2011, and they are four. And in 2022 we have new emerging ones, where four more hallmarks were introduced. And these hallmarks are very important for understanding the concept of cancer. So first one is sustaining and proliferative signaling. So they can stimulate their own growth signals in the absence of external signals. And so sustaining proliferative signaling, where the cancer cells grows continuously uh, without the external growth signals. They create their own growth signals, and they also hijack the normal ones. Example is the overexpression of EGFR mutation in the lung cancer. And second one, evading growth suppressors. Here, they ignore the signals that normally tells a cell to stop dividing, and they undergo programmed cell death. Here, these TP53 gene is the most common with which evades the tumor growth suppressors. And third one is the resisting cell death. So here they bypass this mechanisms that lead to programmed cell death, which is called apoptosis, and allowing them to survive even when there is cell damage. So example of this is a telomerase activity, which is seen in approximately more than 90% of cancers. enabling replicative immortality. Here, they overcome the limitations of cell division, where they normally restrict the number of times a cell can divide and allowing them to proliferate indefinitely. So here we have seen almost example is the similar one with telomerase activity, which is seen in most of the cancers, and inducing angiogenesis. Angiogenesis is the production or formation of new blood vessels or supply system for the cancer cells itself, which provide them oxygen and nutrients, which is essential for their growth and metastasis. So here we can tell the example of VEGF in the colorectal cancer or the renal cell carcinoma, and activating invasion and metastasis. So here they invade surrounding normal tissues and spread to distant sites in the body through blood vessels and lymphatic system, called metastasis. So here we can see the example of EMT mutation in the breast cancer. And the six which I have explained were the classical six markers which were introduced in the 2000. And the emerging hallmarks which have been updated in 2011 and 2022 are these four. Coming to the seventh one, deregulating cellular metabolism. So these cancer cells change their energy production to support their rapid growth. Generally, they use glycolysis even when oxygen is present, like building their own unit for the energy production. Like we can use PET CT scan uh, for the identification of cancers using the same mechanism. So coming to the next one, avoiding immune destruction. So cancer cells become resistant to the attack from the immunity system. So mm, example is the inflammatory bowel disease, which increases the risk of colorectal cancers, and tumor promoting inflammation. So cancer cells which create an inflammatory environment that aids to their development. Example is the Warburg effect. Warburg effect. So uh, sorry, for example of avoiding immune destruction is the PDL1 uh, treatment, which we give in the melanoma, which suppresses the T cell attack. So here the cancer cells gain production from the immunity. And all coming to the next one, genome instability and mutation. So so cancer cells change their characteristics, allowing them to adapt and survive in different conditions, which help them grow further. So coming to the example, we have the BRCA1 in breast cancer, and coming to the new emerging hallmarks which were introduced in the 2022. So see here, unlocking phenotypic plasticity. Here cancer cells can convert themselves into stem-like states. Stem-like states means transforming themselves into the cells, like converting themselves into the stem cells. Stem cells have the potential to differentiate into different types, which helps them to transdifferentiate into other cell types, also giving them adaptability for survival, invasion, and therapy resistance. Uh, Coming to non-mutational epigenetic reprogramming, here epigenetic alterations, examples are DNA methylation, histone modification, chromatin remodeling, drive tumor initiation progression without changes in the DNA sequencing. Example of this is DNA methylation slicing in tumor suppressor genes. Next slide. So polymorphic microbes influencing cancer. So here generally the microbes which are present in our gut, example are the H. pylori infection. Chronic H. pylori infection can cause gastric cancers. and senescent cells promoting cancer. So accumulation of senescent cells in tumors and surrounding tissues contributes to pro-tumorigenic environment through the senescence associated secretory phenotype. Here, these cells go into the non-dividing state and start replication after some time. So coming to the types of cancers, so here we have carcinoma, where the tumors or cancer arises from the epithelial cells of organs that can secrete. Example are the breast cancers, lung cancers, and sarcoma. It is a uncommon type of cancer, and this arises from the bone tissues and soft tissues. So melanoma, it is also an uncommon, like a rare disease, but most dangerous cancer of skin that originates in the pigment producing cells. So brain and spinal cord, it arises from different cells of the central nervous system. Germ cell tumors, it arises mainly in the reproductive cells like sperm cells and the egg cells. So neuroendocrine tumors, cancer arises from the organs that secrete hormones. Example, this thyroid tumors, pituitary tumors. So coming to lymphoma, it is a type of cancer that originates from the lymphatic system like lymph nodes, spleen, thymus, and the bone marrow. And leukemia, it is a type of cancer that generally originates in the blood forming tissues like bone marrow. They may be acute and chronic. And coming to myeloma, it arises in the plasma cells, and which is most common in the old age. So symptoms of cancer include fatigue, unexplained weight loss, lumps over the body. It may be in the inguinal areas, cervical areas, or axillary areas. Persistent cough or hoarseness of voice, easy bruising, oval and bladder changes, unexplained fever, cytopenias, frequent infections, bone and joint pains. So coming to the TMN classification, TNM classification system of malignant tumors was developed by Mr. Pierre Dieners in France between the years of 1943 and 1952. In 1950, a committee was appointed on tumor for nomenclature and statistics. So these are the publications. Currently, we are in the 8th edition of this publication. Next slide. So coming to the general principle of this TNM classification is mainly to aid the clinician in planning the treatment. So once the staging is done, it helps the clinician to decide the regimen, and also give some indication on prognosis. So like example, when we have a stage 4 cancer, we can tell that there are limited options for the treatment, and to assist in evaluation of the results of the treatment. For example, if we have a stage 3 lymphoma, after the treatment, we can reassess with the PET CT scan and restage it, so that we can see the difference in the disease status, so that we can judge the results of the treatment. Back 11. To facilitate the exchange of information between treatment centers, to contribute the continuing investigation of human cancer, and also to support cancer control activities. So here we have the general rules of TNM classification. T stands for the extent of primary tumor. N stands for the absence or presence of regional lymph node metastasis, and M stands for the presence or absence of metastasis. So T, which is the primary tumor, here TX, primary tumor cannot be assessed. T0, no evidence of primary tumor. TIS, carcinoma in situ, and we have stages from T1 to T4. T1 to T4 is the increasing size and or local extent of the tumor, primary tumor. Similar to the primary tumor, here we assess for the regional lymph nodes. So NX means regional lymph nodes cannot be assessed. N0, where regional lymph node metastasis is absent, and N1 to N3, increasing involvement of the regional lymph nodes. And M stands for the distant metastasis, M0 no distant metastasis, and M1 presence of distant metastasis. And note, see, here there are subdivisions available for those who need greater specificity. So in primary tumor, we have staging like T1A and B, and even also even in the lymph nodes also like 2A and 2B. Next slide. So in TNM classifications, we have both suffixes and prefixes. So suffix, coming to the suffix SN, which is the sentinel lymph node, where the primary tumor extends to the first lymph node. And I plus or I minus is the presence of isolated tumor cells. Presence or absence can be determined. Oh, sir, back alone. So MOL plus or minus, here we can find the presence or absence of non-morphological findings of isolated tumor cells. So coming to the so here C indicates clinical diagnosis, and P indicates for the pathological classification, small m for the presence of multiple primary tumors, Y like during or following multimodality therapy. So R, small r for the recurrent tumors. A for classification is first determined at autopsy. L, capital L for the lymphatic invasion, capital V for venous invasion, and PN for the perineural invasion, and capital R for residual tumor. So here we also have the grading. So Gx, grade of differentiation cannot be assessed. So G1 well differentiated, G2 moderately differentiated, G3 poorly differentiated, G4 undifferentiated. So here the differentiation comes for the prognosis of the treatment. So generally, this is a basic information which we can tell, like what is the stages. So for stage 0, primary tumor is in situ, but they don't have any lymph node or metastasis. So carcinoma in situ, stage 1. So here primary tumor is around 1 to 2 grade, and no lymph node and metastasis involved. So localized cancer. In stage 2, we have tumor for 1 to 2 stages, and lymph node is stage 1, and metastasis is 0. So locally advanced cancer, early stages. In stage 3, we have the primary tumor of staging around 1 to 4, lymph node involvement around 2 to 3 stages, and no metastasis. So locally advanced cancer, this is the late stages, and stage 4, we have the metastasis. So whenever we see a metastasis present, so it is directly a stage 4 cancer. And coming to the blood cancers, so unlike solid organ cancers, there is no staging in the blood cancers. We only have the risk stratification, which helps us in guiding the treatment. So generally, the diagnosis of cancer involves blood investigations. So blood investigations here, they may be local, no, regular blood tests like CBC, LFT, creatinine, and also the tumor markers. Generally, the tumor markers are proteins which are which are released by the tumor cells itself or by the body in the presence of cancer cells, and these also help us in determining and prognosticating the cancer, even for screening of the cancers. Examples are the PSA, which we use for the screening of prostate cancer, LDH for the lymphomas and leukemias, and histopathological studies, which are biopsies, radiological studies, which include CT, MRI, and PET-CT scans, and molecular studies. So treatment of cancers, it generally includes chemotherapy. We have three types of chemotherapy. So neoadjuvant chemotherapy is primarily is given to shrink the disease, where we can uh, go for the surgery or radiotherapy if the disease load is high, and main objective is to shrink the disease. And primary chemotherapy, its main intention is to clear the disease. And adjuvant chemotherapy, which is given after the primary chemotherapy, which kills the residual cancer cells. And we have surgery to remove the disease cancer cells. And radiotherapy, we can use a combination of chemotherapy, surgery, and radiotherapy in few patients. And we also have bone marrow transplantation. So coming to the recent advances in oncology, so here we have liquid biopsies, where we use a blood sample to identify the cancers. We have targeted therapy, which we can directly target the cancer cells. Examples are the so examples of targeted therapy include involves the imatinib, which we give for the CML, chronic myeloid leukemia, and immunotherapy, where we use monoclonal antibodies to remove the cancer cells. Examples are the rituximab, trastuzumab, and all. Coming to the CAR T cell therapy, here we presently have only uh, therapy to the B lineage cells, mostly to the B lineage cells, where the T cells are removed and transformed into chimeric antigen receptors, which attacks the B cells producing cancers. And personalized therapies based on the individuals, we can personalize their therapies. So coming to the psychological impacts of cancer, so uh, whenever the whenever the patients get the diagnosis of cancer, we have many psychological impacts. So I'll briefly explain them. So coming to the diagnosis part, so whenever a patient is diagnosed with the cancer, so first step is the emotional distress. They'll be in shock, they'll be in denial that they have the cancer, they'll be in fear that the cancer is curable or not. And they'll be having stigma and identity crisis, like whenever they go for the chemotherapy, they'll be having alopecia. So body changes, some may have pigmentation over skin, so they think that their identity may be at problem. And they'll be have uncertainty and loss of control because of fear of recurrence. And during treatment, they have chemotherapy, and we have chemotherapy and radiotherapy, which causes them fatigue, sleep disturbances, and also a condition called chemo brain, where the patient have cognitive impairment. And also anxiety related to procedures. So whenever we tell them to go for a surgery, they'll be having anxiety. And impact on family, so caregivers often express stress, mainly due to the burden of the disease. And coming to the survivorship and long term effects, the first thing will be the fear of recurrence, which is the most common. And adjustment issues. So coming to the adjustment issues, they'll be having difficulties in returning to their work and relationship status. They also have the fertility issues, because we have some chemotherapies which uh, affects on their fertility. And post traumatic growth, so here some patients face greater appreciation of life and improved priorities. So psychological disorders, here we mainly see the depression, anxiety disorders, and delirium. Some people uh, have delirium mainly in the advanced cancers, and coping mechanism here adapt first comes the adapter, where the problem solving, seeking support, acceptance, and positive reframing will be seen. And maladaptive, here they'll be continually having the denial, avoidance of support. Sometimes they even refuse to take the treatment. And religious, here they have many cultures which tell them to take different types of treatment based on their cultures. Coming to the next slide. So role of psycho-oncology, here we first thing is to screen for the distress, and we can solve their issues by interventions, mainly helping them with the cognitive behavioral therapy, training them with the mindfulness and relaxations, and psychoeducation of families and patients, and pharmacological support whenever needed to reduce depression and anxiety. So end of life and palliative care, here psychological support is very essential for acceptance of disease, and also reducing the existential distress. So family counseling and grief support is very crucial. So coming to the key takeaways, oncology is the study and treatment of cancer. Cancer is not one disease, but it is a group of disorders. So tumors can be benign, pre-malignant, and malignant. So TNM classification is introduced only to help the clinician take decisions, make a prognosis out of this, and checking the results after the treatment. And we have modern oncology integrations with precision diagnostics and advanced therapies, even the personalized therapies. So these are the references. And thank you. If you have any doubts, you can reach us through the FCPA official mail IDs. You can mail us in through Gmail, LinkedIn, or the Instagram, or official Facebook pages. Yeah, thank you.
Thank you, Dr. Vikas, for sharing your valuable information. I hope everyone are introduced. Thank you all for your valuable time. We'll meet you again with another presentation.